So when you are inserting, you have to insert these blades inside the nasal cavity. When you are inserting, you have to squeeze your middle finger and ring finger so that all the blades will come together and the blades will close. So you have to close the thudicum nasal speculum. Then you have to insert inside the nasal cavity. Then you have to release these prongs so that the blades will again open and it will separate the lateral wall, separate the nasal wall or vestibular wall. So you have to close it completely, then insert inside, because if you are inserting with an open blade, then there are chances of injury. So you have to close it completely, insert inside the nasal cavity, then you have to release. Okay. So then you perform whatever you want to do. But after doing your maneuver, when you are taking out the speculum, the most important thing is you do not close it completely. You have to keep it a little separated when you are taking it out from the nasal cavity. Why? Because when you are taking it out from the nasal cavity, what may happen, some vibrissae or some of the hairs inside the vestibule that may get entrapped in between the blades. So if you close it completely and then take it out, so there are chances that you may pull some of the hair from the nasal vestibular area, so that will cause a tremendous pain to the patient. So when taking it out, you have to keep it little open. While inserting, you have to close it completely. When you are taking it out, you have to keep both the blades a little open. Okay, so this is all about thudicum nasal speculum. Next is, for examination of the ear, we use a oral speculum. This is a funnel shaped tubular structure having two openings at the two ends. So the narrowest opening will be inserted inside the ear canal, and so that we can visualize to the other end the inside of the ear canal properly. So it is used, the particular ear speculum that will be given to you. These are all practical instruments that will be given to you. So I have taken the photographs and showing it to you. So this particular ear speculum is known as Hartmann's oral speculum. Okay. So this is used to examine the external ear canal and tympanic membrane. Up to the tympanic membrane you can examine, and also the middle ear when the tympanic membrane is perforated. But in the intact tympanic membrane, you cannot see the middle ear through the oral speculum. So you can just examine, or you can perform certain maneuvers, like you can remove the wax, or you can remove a foreign body, or any automacotic debris or ear discharge inside the ear canal. You can just clean it through this speculum by putting the speculum in the ear and wearing a head mirror. You can throw the light to the inside of the canal through this larger opening, and you can maneuver your instruments through this opening into the canal. Okay. So in intraoperative procedures like myringotomy, myringoplasty, staphyloctomy, or staphydectomy, you can use these instruments to visualize the inside of the middle ear. And also for transcanal injections, you can use this ear speculum. Okay. So this is all about oral speculum. So next in the next instrument will be shown or asked in the examination is indirect laryngoscopy mirror. These are all OPD instruments. You might have seen them in the ENT OPD. The doctors or the surgeons, you might have seen them using these instruments in the OPD. So most of you must have seen these mirrors. So this is an indirect laryngoscopy mirror. Why it is called indirect laryngoscopy mirror? Okay, so if it is indirect, there must be some indirect methods of examination also. It is called indirect because we are examining the inside of the larynx, because it's a laryngoscopy mirror. We are examining the inside of the larynx indirectly through a mirror. We are not seeing the actual picture of the inside of the larynx. We are seeing the structures indirectly through the mirror. We are seeing the mirror image of the structures inside of the larynx. Okay, so that is why it is called indirect laryngoscopy mirror. So there is another method of direct laryngoscopy. For that, the patient has to be sedated, or a patient has to be anesthetized inside the OT, and we have to insert the laryngoscope. The laryngoscope, the different types of laryngoscopes are there. We have to insert the laryngoscope inside the larynx. Then we have to visualize, and we can take a biopsy, or we can do a surgery, whatever we want to do. That's a direct laryngoscopy. And in the OPD, we are seeing it through an indirect laryngoscopy mirror. There are other methods of examining the larynx in the OPD also, that are also direct methods, that is using a laryngeal endoscope, or the recent method is the stroboscope. They say fiber optic stroboscope we can use inside the we can use we can insert into the oral cavity and go up to the larynx. From the tip of the stroboscope, the image of the larynx will be received and it will be displayed in the monitor. We can see the magnified view of the larynx. That is a direct way of also examination of the larynx. But here we are focused, this is a basic method of examination of the larynx, the indirect laryngoscopy. So coming to the parts of this instrument, it has got a handle, it has got a shaft, and it has got a mirror. A handle to be hold. This is a shaft, and this is a mirror. This mirror is present at an angle to this shaft. Okay, it is not present in a horizontal fashion. It is present at an angle, so that we can the angle we can see the inside of the larynx. The focal length of this mirror is at infinity because it's a plane mirror. It is not a concave or a convex mirror. It's a plane mirror. The focal length is at the infinity. And the mirrors are of different sizes, from varying from 8 millimeter to 30 millimeter, depending on the age of the patient. For the pediatric age group, we use a smaller mirror. For the adult patients, we can use a bigger. We need a bigger mirror. So there are various sizes are available. It can be small. It can be a larger one. So before coming to its uses, let us discuss about how we perform indirect laryngoscopy, because we will be asked in the examination. Okay, I don't know whether we have been taught or not, but for indirect laryngoscopy, the setup, the patient has to sit. The patient and the examiner both have to sit on this revolving stool. The head of the patient should be at the unfortunately, the head of the examiner is not visible here. The head of the examiner and the head of the patient should be at the same level. Okay, it should be at the same level, and you can see the light of the head bullseye lamp getting reflected over the hair of the patient. The left ear, this is the left ear, and 30 centimeter behind the left ear is placed the head lamp. The light is coming from here. It is getting reflected from the head mirror of the examiner, and it is getting reflected and coming and falling on the inside of the oral cavity. Okay, so this is the setup of making the patient seated and how to examine the patient. Then, how you will perform the indirect laryngoscopy? To perform indirect laryngoscopy, the mouth should be open. Otherwise, how can you see the inside of the larynx? How can you insert the mirror? The mouth should be open, and the tongue of the patient should be pulled outward with the help of a gauze piece by the examiner. The examiner holds the tongue with the help of a gauze piece with his thumb and middle finger. The index finger rests on the upper jaw, so that to give support and to keep the mouth open, and pulls the tongue outwards. Okay, and asks the patient to take breath through the mouth. Okay, then what will happen? The examiner holds the indirect laryngoscopy mirror in his dominant hand in a pen holding like fashion. It's just like as if he is holding a pen, not like a dagger, just like a pen, or not like in stabbing fashion. Only very gently, just like a pen holding fashion, he has to hold it with the mirror facing below, not above, because we want to examine the inside of the larynx, so mirror has to face below. Okay, okay. So just before inserting the mirror into the oral cavity, so that light will come and fall on this mirror, light will come and fall on this mirror. Because of its angulation, the light will be getting reflected and coming to the down. Because I want to show you all these things, therefore I have deliberately kept the mirror outside, not inside. Then I wouldn't be able to show you the mechanism. The light will be coming from his head mirror, will be falling on the mirror of the indirect laryngoscopy, this IL mirror, and it will get reflected, and it will fall in the into the larynx. The reflected light from the larynx will again come and fall on the mirror, and the images will be visible by the examiner. So before inserting this mirror into the oral cavity, what you have to do is very important thing is you have to warm this mirror. Why? Why you have to warm? Because the air coming out through the breath of the patient, that may come in contact with the mirror, the cold surface of the mirror, and that will cause fogging. Then you cannot see anything what you want to see. So therefore, in order to prevent fogging of this mirror, you have to warm it with the help of a either of the spirit lamp, or you can just rub this mirror the inside buccal mucosa of the inside of his cheek of the patient, so that the by rubbing it, it can become a little bit warm. So after warming it, what you have to do, you have to examine whether it is too much hot or just warm, just by pressing it over the backside of your hand. Okay, this is a glass part, and the behind is a metallic part. You have to toss this metallic part with on the backside of the hand, and you have to examine whether it is too much hot or just warm. Too much hot will cause this hitting injury to the mucosa of the oral cavity. So you have to reduce the temperature to just to the body temperature, then you have to insert it. Otherwise, you can use certain defogging agents like Savlon. You can rub some little bit of Savlon over the this glass part, then you can insert inside the oral cavity, and you can examine the larynx. So when after inserting the mirror into the oral cavity, ask the patient to say E, short E. Ask the patient to say E, so that you can see the abduction of the vocal cords and movement of the vocal cords, abduction and adduction. Each time the patient says E, it will be adducted, and then it will be abducted, adducted, and abducted. So you can see the mobility of the vocal cord. You can see the vibration of the vocal cord. You can see any irregularity or any swelling or any growth inside the vocal cord. You can visualize the base of the tongue. You can visualize the epiglottis, you can visualize the vallicula, you can visualize the median glossoepiglottic fold, the ariepiglottic folds, arytenoids, piriform fossa, interarytenoid area. You can visualize the false chord, you can visualize the true chord, you can visualize in some cases also inside of the trachea. Just below the larynx is the trachea. You can visualize in some cases the tracheal rings that can be visible in a few patients also. The inside of the trachea up to the upper part of the trachea can also be visualized through a indirect laryngoscopy method. So what are the uses of this mirror? So for what purpose you want to use it? So as I told, for examination of tongue base, vallicula, and all those things. Okay, postopharyngeal wall. These regions can be examined for any. You want to just by examining, you can see the normal structures, how it is different from the abnormality. If there is any, just like growth or ulcer or any bleeding point or any foreign body. If there is any foreign body, like just like fish bone, you can remove it. Or to remove any tissue for histopathological examination. If there is an abnormal growth, you can just visualize to the mirror on the left hand, and to the right hand you can hold the instrument, and you can go to that particular part and take a little bit of tissue from that particular abnormal growth and send it for histopathological examination. So you can use it for examination, you can use for removal of the foreign body, and you can use for taking a biopsy. So indirect laryngoscopy and its uses. Okay. So this is about examining the inside of the larynx. So similarly, so there are certain pitfalls or the disadvantages of indirect laryngoscopy. There are few structures that cannot be seen in this procedure. You can take a screenshot of this slide because I'm not going to the details. So post-cricoid area affects the piriform fossa, ventricles, undersurface of vocal cords and adjoining subglottic regions, laryngeal surface of the epiglottis. These are the structures which you cannot see through a indirect laryngoscopy. For that, you need a direct laryngoscopy. Indirect laryngoscopy has got some advantages and some loopholes also. The pitfalls of indirect laryngoscopy mirror examination are also many. So if I will tell the details, then it will take a very long time. So I'm skipping the slide, but these are very important points. You can take a screenshot and see it later, read it later. The next examination will be posterior rhinoscopy examination. Okay, why it is posterior rhinoscopy examination? Previously, I have already told you anterior rhinoscopy by Thudicum's nasal speculum. That is, we are examining the anterior part of the nasal cavity. Through this posterior rhinoscopy mirror, we can examine the posterior part of the nasal cavity. Okay, this particular mirror that we use for posterior rhinoscopy is known as St. Clair Thompson's posterior rhinoscopy mirror. Okay, this mirror is known as St. Clair Thompson's posterior rhinoscopy mirror. You'll be asked in the exam what is the name of this mirror. Okay, so so it is unlike the indirect laryngoscopy mirror, the posterior rhinoscopy mirror is a is a Benner separate in its shape. It is a Benner separate. So having a bent at the middle. Why it is bent at the middle? So that the examiner can examine the inside of the when he is inserting it into the oral cavity, the tongue will come in between, and so that the tongue will not obscure the vision. So it is bent at the middle. Okay, so the mirror is available in the sizes of it is also a plain mirror. It has got a handle. It is a shaft is bent, and the mirror is attached to the shaft at an angle. So it is a various sizes of 0 to 5 of different sizes depending on the age of the patient. You can use the light will come and get reflected over here. This attached at an angle, so it will go and fall on the posterior part of the nasal cavity. The mirror surface is either heated or dipped in saffron, as I told you. The tongue is depressed. The method. The tongue is depressed gently with a tongue depressor, and this mirror is introduced inside like a pen with a mirror facing upwards. Okay, so just like indirect laryngoscopy, there see the difference. Just mark the difference. The patient is sitting at the same method of sitting the patient and the examiner at the same level of the head. There we are holding the tongue and pulling it outside, but here we are depressing the tongue with the help of a tongue depressor. Okay, if you can just remember, you can recollect. We are depressing the tongue with the help of a tongue depressor. We are not holding the tongue. Okay, there we ask the patient to take breath through the mouth. Here we will ask the patient to take breath through the nose, so that palate will hang. Okay, so if your patient takes breath through the mouth, what will happen? That palate will get elevated, and we want to see here the purpose is to see the posterior part of the nasal cavity, so that the nasopharynx should be spacious. So that when it will be spacious, when the palate falls, soft palate falls downwards. So only when the patient takes the breath through the nose, the palate will fall downwards and nasopharynx will become patulous, so that we can insert this mirror just behind the soft palate. Again, we will hold it in a pen holding like manner. We will insert it after warming or smearing with saffron, that is anti-fogging agent. We have to insert. This bend will be resting over the tongue, so that if had it been straight, the tongue would have obscured the vision. So that is why it is being made at this end, so that this the tongue will be accommodated here, and there will, the hand will not come in front of the mirror. So we can make the light from the head mirror fall on this mirror, that will get reflected anteriorly, will fall on the posterior part of the nasal cavity. The reflected image, reflected light from that part will again fall here. It will come and the image will be created in the eye of the examiner. So we have to insert it behind the soft palate. Okay, then you have to examine. So what are the things we want to see? Posterior anoscopy, the different structures you can see is the posterior part of the septum, posterior part of the inferior turbinate, the choana, the adenoids, the torus tubaris, the fossa frogenmolar, all those things. And another important thing I want to tell you, all of you, please practice few diagrams that you will be asked to draw in the examination. What are the diagrams you have to practice? The diagrams of left and right tympanic membrane, diagram of indirect laryngoscopy image, diagram of posterior rhinoscopy image. So how the posterior rhinoscopy, the things will be visualized, you have to draw a diagram. That is there in your book, the textbook you are following. You have to practice these 3-4 diagrams at least. Anyone can be asked to draw a diagram of the indirect laryngoscopy or a diagram of the posterior rhinoscopy. Okay, so for that you must know what are the structures we are going to see in a posterior rhinoscopy. Posterior part of the nasal septum, then the choana, the posterior ends of the inferior turbinate, then the roof of the nasopharynx, adenoids, fossa frogenmolar, torus tubaris, all these things you can visualize. Okay, so this is all about posterior anoscopic examination. Details you will read in your book. Next will be tuning fork. The tuning fork, you must be knowing what is a tuning fork. So it has got a few parts. Different types of Hartmann tuning fork and Gardiner tuning forks are different types of tuning forks are there. but you will be given a metallic tuning fork, that is a Gardiner tuning fork type. So it has got few parts. It has got two prongs, a shoulder, a stem, and a base. Okay, so this is a stem, this is shoulder, these are two prongs, and this is a base. So this tuning fork, the two prongs, how you will use the tuning fork? You have to strike the tuning fork on a firm place, just like the hypothenar eminence of your hand or on the elbow. You have to strike it, strike the prong of the tuning fork to create a vibration. Where you will strike? It will strike at the junction of the upper one third and lower two third. Here only you have to strike approximately upper one third and lower two third at the junction of this. You have to strike the tuning fork, create a vibration, and this vibration will create some sound. Okay, then you have to place the tuning fork near your ear at, differently for air conduction and bone conduction, and you have to examine. So for examining air conduction, you have to place a vibrating tuning fork at an axis at a perpendicular axis to the ear at a distance of 2.5 centimeter from the auricle. 2.5 centimeter from the auricle, you have to place the vibrating tuning fork at an angle at a right angle to the axis of the ear canal. Okay, just like you have to place it. Okay, so vibration will be transmitted to inside of the ear canal. But for bone conduction, you have to place the tuning fork over the mastered process. The base of the tuning fork you have to place over the mastered process. So tuning forks are available in different frequencies like 128, 256, 512, and 1024 hertz frequencies are available. So the different frequencies have got different uses, but the most common frequency that is used clinically is 512 hertz tuning fork because it is present in the mid speech frequency range. Okay, because it corresponds to the mid speech frequency. Overtones are minimal, and sound is more auditory than tactile in nature because the sound will be more audible than the vibration sensation, and tone decay is optimal. So the decay time will be more. So once you set it into vibration, the sound will be there for a pretty long period. So 512 tuning fork is most commonly used. And the uses, why, in which condition you have to use it to detect the type of hearing loss. Okay, so you must be knowing what is Rini test, what is Weber test, what is absolute bone conduction test. Many tests are there, Gelli test, Chimani-Moose test, many other tests are there. I'm not going to detail. You have to read it from your books. This will be asked in the exam. So to detect the type of hearing loss, conductive hearing loss, or sensory loss, sensory neural hearing loss, you can detect to make an approximate estimate of the degree of hearing loss. Okay, whether it is mild or moderate or severe or profound, you can examine by this tuning forks using all the frequencies 128, 256, 512, 1024. All the frequencies of tuning fork you can use to know. This is called serial tuning fork test or TFT, serial tuning fork test. In serial tuning fork test, all the frequencies are tested, and you can from these using all the four frequencies you can know which frequencies are had and which frequencies are not had, and accordingly you can know whether the loss is mild or the moderate or severe or profound. Okay, so to know the type of hearing loss and to know the degree of hearing loss, you can use a tuning fork. So there are other uses of tuning fork also to know the vibration sensation. That is, in neurology you can use it to know over the joints and all those things. So I'm not going to details. The next in the OPD, you will be the next instrument in the OPD you can see is a tongue depressor. The tongue depressor is the most versatile instrument that is available there. So there are different types of tongue depressor. This particular instrument is known as lax tongue depressor, and another one, straight tongue depressor, you can also see. So this lax tongue depressor has got a is a right angle in shape, and it has got a flat and slightly curved end. This end is flat, and this one is slightly curved, because this is to be held by the hand, so the hand will not slip, so it slip off from the instrument. It is a bit curved at its lower point, but this particular horizontal part is flat and it is broad. It is narrow and curved. This is flat and broad. So you have to place this tongue depressor over the dorsum of the tongue. But the most important thing is you should not touch the posterior third of the tongue. You have to place this flat surface of the tongue depressor over the anterior two-third of the tongue, because posterior two-third will be, if you touch it, there will be severe gagging. So in order to prevent gagging, or you have to ensure the cooperation of the patient, you have to place the tongue depressor over the anterior two-third of the tongue. Okay. Otherwise, the patient will gag severely, and he or she will not cooperate you in the examination. So there are different uses. So examination of the oral cavity and oropharynx to retract the lips and cheeks, to examine, to express pus out of the tonsil, that in septic squeeze test, and you must be knowing that is known as Irwin-Moore sign. In septic tonsillitis, chronic tonsillitis, if you press the anterior pillar with a tongue depressor, some chichi material will come out from the surface. That is known as Irwin-Moore sign. Okay, so for that you can use a tongue depressor. To test the gag reflex, if you touch the posterior part of the tongue or the posterior pharyngeal wall, there will be gagging. So to know whether it's a very important test, neurological test, to know the intactness of the cranial nerves, you have to use a gag reflex test using a tongue depressor. Also, it can be used as a cold spatula test to check the patency of the passage. You cold the surface of this metal, because it's metal, the surface is make it cold, and place it just below the nose, and ask the patient to breathe normally. Because the exhaled air is warm, when this warm air comes in contact with the cold surface of the tongue depressor, there will be fogging. So by seeing the fogging of the two fogging sides from the two nostrils will be there on the surface of the tongue depressor. So by seeing the size of the fogging area, or whether it's the presence or absence of the fogging area, we can know if there is if the both the nasal cavity are patent, or if it is completely blocked, or if it's incompletely blocked, or which side is blocked, how much. So this is called as cold spatula test. We can use it for a posterior anoscopy, as I told you, by depressing the tongue. For oral cavity procedures like injection of steroids, pipes, excision of cyst, etc., we can use a tongue depressor. So now this instrument you have not seen in the OPD. This is a OT instrument. This is known as St. Clair Thompson's Quincy forceps. Quincy is a peritonsillar abscess. So peritonsillar abscess has to be drained using this forceps. So this is also a Bernard Seppert instrument, having a sharp tip. Okay, sharp tip, and just behind the tip there is a guard. Okay, this what you have to do, you have to close this instrument, insert it inside the oral cavity. In case of peritonsillar abscess, you have to stab it with the tip of the instrument, create a hole in the abscess cavity, and drain the abscess that is present inside the peritonsillar space. Okay, then you have to, and the guard is there because this guard will prevent excessive insertion of the instrument into the soft tissues. Okay, so to prevent the excessive insertion, the guard is there. So this tip is very pointed and sharp, so you can insert it inside the abscess. Then you have to open it little bit. Okay, the edge of the instrument is sharp, so that it will cut the soft tissues. Okay, it will you have to open it, then again close it, again rotate the instrument 90 degree, and again you have to open, so that you can give a cruciate incision over the abscess that is present in the peritonsillar area. Okay, instrument then opened like a sinus forceps to drain the abscess. So this is a Quincy forceps, or St. Clair Thompson's Quincy forceps. We have to insert it in the oral cavity. What is Quincy? Where it will be drained? What is exact site of drain? What are the symptoms? What are the complications? Everything you have to examine. You have to go through the book. I cannot tell details. So what is the site I'm telling you? The site of puncture of the peritonsillar abscess is at the site of maximum bulge. Certainly to the soft tissues will be less. So you have to insert there and drain the abscess. Or else there is another point is, you draw a line at the base of the uvula, a horizontal line at the base of the uvula, and another vertical line on the anterior pillar. Anterior pillar, you draw a vertical line. At the base of uvula, you draw a horizontal line. The point where these vertical and horizontal lines meet, there you can puncture to drain the peritonsillar abscess. So this is all about Quincy forceps. The next will be tonsillectomy. So tonsillectomy is very important as far as your examination point of view is concerned. So there are different indications of tonsillectomy. You will read in your book. So the instruments used for tonsillectomy is, first is boiled Davis mouth gag, because the tonsil is present inside the oral cavity. While performing surgery, the oral cavity has to remain open. You have to you have to retract both the upper and lower jaws, separate and fix it at a particular distance, so that you can do some maneuver inside the oral cavity. So this is a gag. This mouth gag helps in doing that. So mouth gag has got two parts. It has got a boil blade and a Davis gag. This is a blade and this is the gag. Okay, this blade will be fitted to the gag, and this combined instrument is known as boil Davis mouth gag. It helps in keeping the mouth open and push the tongue up and away from the operation side. Upper tooth plate has a small holes. You can see this gag has got a slot over here. It has got a lock here. This is the shaft, and this is a rest. This is particularly made to rest on the upper jaw teeth. Okay, here the upper jaw teeth will be locked, and this blade will be fitted in this slot. As you can see, this is the lock over here. This blade will be pressing the tongue below, and this will be pushing the upper jaw above. This is to pull the lower jaw. This is to push the upper jaw. So you have to insert this. Here the gag is partially open, but while inserting, you have to close it. But this gap is to be closed, and then you have to insert it into the oral cavity. Then you have to pull this blade downwards. This lock will keep the blade fixed, separated at a fixed point. The locking mechanism is there. After inserting the mouth gag in a closed fashion into the oral cavity, you have to pull it so that the blade will be separated from the upper jaw rest. So this is a ratchet mechanism over here. We can it's not visible from here, but on the dorsal surface there are a few ridges, and this ridge will be locked in this ratchet, so that it will again not come back to its original position. The uses: it is used for tonsillectomy, for adenoidectomy, for surgeries of palate and nasopharynx, and excision of the choanal polyp. So to aid this boiled Davis mouth gag to be held in this particular position, we need a stand, that is known as Draffin's Viper stand. Okay, this is nothing but just a simple rod having few rings attached at the at one end. So instead, construct two rods with multiple rings in a row, used as an anchor, and fix the boiled Davis mouth gag for numerous oropharyngeal surgeries, including adenotonsillectomy. I can show you in the next picture. Here's a ratchet locking mechanism. Okay, so after inserting the blade and the chin, the blade and the upper jaw rest, they are separated by pulling it from here, and this is kept in position by using a Draffin's Viper stand. Okay, so this is the position of the patient. This is the rose position. You have to place a shoulder, a sandbag just below the shoulder, so that the neck will be in extension position. So after placing the patient, I can see the endotracheal tube over here. The patient is being operated under general anesthesia. So after putting the patient under GA, you have to place a sandbag, and then you have to insert the mouth gag and use a Draffin's bipod. Then you can go for tonsillectomy. Starting, you can see the tonsil. This is the undissected tonsil and dissected tonsil. You have to hold the tonsil. You have to dissect the tonsil from the upper pole and go to the lower pole. See here, the oral cavity is inverted. This is the uvula. This is the tongue base. Okay. So ideally, this is the upper one. This upper pole. This is the upper end. This is the lower end. So since the patient is sleeping supine, it has come downwards. So this is the upper pole. This is the lower pole. This is the upper pole. This is the lower pole. The tonsil, when we are operating, it will have to operate from the upper pole and go towards the lower pole. So the upper pole is held with an instrument. Then you have to dissect it from its bed. You have to go to the lower pole, and from the lower pole you can excise it with a snare. I will be showing those instruments gradually. So this is Colver tonsillar valsalem forceps. You can take note of it. Colver tonsillar valsalum forceps. This instrument is used to hold this upper pole. Okay, you have to hold this upper pole with the use of this valsalum. This valsalum is nothing but a you have to hold the upper pole and pull it medially. Okay, prior to dissection. So especially useful where the tonsil is friable and the grip cannot be changed repeatedly. Okay, once you it is a curved instrument having a curved tip, the tip having serrations. Okay, so the curvature is because we can give a better visualization, and because of the serration at the tip of this instrument, you can have a good grip of the tonsil. Once you grip the upper pole of the tonsil, it will not slip off. Okay, so this is all about tonsillar valsalum forceps. Next is lock forceps. This is this you can use this instrument also to hold the tonsil, but there are other uses of it also. I will be telling you. This will be given to you in your examination. This forceps has a screw joint. This is the screw joint over here, and has a fenestrated tip. The tip you can see there are fenestra. Okay, and there are sharp blades. The blades are very sharp. This instrument will be given to you. This is taken from other sources, but this is the practical instrument that will be given in the examination. This is a fenestrated tip. This is a screw joint, and these are the sharp blades. Okay, to grasp the tissue and cut it. Hence, this forceps is suitable for biopsy of various soft tissues and delicate bones. You can cut delicate bones with the help of this instrument. Also, you can take a biopsy. Uses are submucosal resection or septoplasty for removal of cartilage and bone in the nose. You can use it for polypectomy and cardiac operation. You can take biopsy from oral cavity and oropharynx, and you can also use this instrument for excising the turbinates, enlarged turbinates, that is turbinectomy. So this is all about Locke's forceps. So the next instrument in the tonsillectomy is a Mollison's tonsillar blunt dissector and anterpillar retractor. Very long name, but the use is very simple. This is a Mollison's tonsillar blunt dissector. This end is blunt. Okay, so this is blunt dissector, dissect the tonsil from its bed, and this is anterior pillar retractor. After taking out the tonsil, you have to retract the anterior pillar to see if any residual tonsillar tissue has been left or not. So this is the use of this instrument, anterior pillar retractor, and this is a blunt dissector. Blunt end used for initial non-traumatic dissection of the tonsil. The retracting end is used to retract the anterior pillar to look for bleeding points and tags of tonsillar tissues that is left behind. This is Mollison's tonsillar blunt dissector. So this is another instrument. This is for giving an initial incision over the anterior pillar of the tonsil, and this is a dissector. This will not be given. So next instrument in the tonsillectomy is wax. Sorry, it has been wrongly written. Wax tonsillar forceps. Okay, wax tonsillar forceps. So this forceps having a this just like a normal forceps, but the teeth is the tip is teeth. There is a teeth and a catch over here, groove over here at the tip of the instrument. This is a very long forceps having a there's a grip over here so that it will not slip up from your fingers. So you can this teeth can be used to give an incision over the mucosa of the anterior pillar at the start of the incision. Also, you can hold a cotton ball with the help of the tip of this instrument, and you can dissect the tonsil from its bed by a gauge dissection method. Okay, the normal method of dissection of tonsil is gauge dissection method that is classically being done. So you can use a cotton piece or a gauze piece to dissect the tonsil from its bed with the help of this tooth instrument. And there is a stud one. There is a stud. Okay, this is called stud. This is a stud in the middle of the instrument, and there is a hole over here. So while holding something at the tip of the instrument, by seeing the stud getting inserted into the hole, you can see the depth of insertion of this stud. You can see, and you can guess how much is the pressure at the tip. Okay. There is stud in one of the arms that can be felt through a vent in the opposite arm. There is a vent and there is a stud. This is useful to note the pressure exerted at the tip. So while doing tonsillectomy, there may be some bleeding because tonsillectomy is known for its complications as a bleeding. So you must be having suction at your hand to keep the field of your surgery always blood free. So you have to use a suction tube like this. This is called Youngker suction tube. This is a special type of tonsillectomy. The suction tube used for tonsillectomy. It is long bent instrument with a stout handle. Okay, for a good grip, yeah, it has got a stout handle, but it is bent to give a good visualization from above. Tip of the tube has a rounded blunt. The tip is blunt. Okay, the blunt cap is there along with few holes over the tip. This prevents trauma to the dissection field, and the bent tube enables the surgeons to visualize the dissection field better. The multiple openings, the tip of the suction tube will facilitate suction even if the main opening is blocked. Even if this main entrance is blocked, there are several other openings at the side of the tip through which suction can be possible if the main entrance is blocked. So what are its uses? It is used for all oral and oropharyngeal surgeries, including adenotonsillectomy, besides maxillectomy, laryngectomy, and other neck surgeries. Okay, any surgery where profuse bleeding is anticipated because it's a very large suction tube, you can use this suction tube for those procedures. Okay. Just after you have given the incision, you have hold the upper pole of the tonsil, you have started dissecting the upper pole, you have dissected the tonsil from its bed. Now you have come down to the lower pole. So lower pole you have to be very careful because all the vessels of the tonsil that enter to the tonsil at its lower pole. So the vascular pedicule is at the lower pole. So you have to be careful while dissecting the tonsil at its lower pole. So for that, a particular instrument is being used that is known as tonsillar snare. The name is Eve tonsillar snare. Eve tonsillar snare. Eve, Eve. Okay. Adam and Eve. Eve, Eve, Eve tonsillar snare. So it is this instrument will be given to you particularly. It has got a finger rest. It is a thumb rest. You can insert the thumb over here, two index and middle fingers over here. At the tip of the instrument, there is a steel wire which is around 3 inches in length and thickness of 28 gauge. It is used to snare the lower pole of tonsil. You have to engage this loop of the wire at the lower pole of the tonsil. Then again, you have to squeeze this thumb and your middle and index fingers. You have to keep them opposed so that this thread will be drawn inside, and the whatever tissue is being held in the loop of this wire, that will be crossed. The lower pole is crossed on snaring, and thromboplastin is released. Why we are crossing it? Why we are using a snare? Why we are not cutting it directly? Because by snaring, we are creating more tissue injury, so that tissue factors will be released. Tissue thromboplastin will be released, which is a powerful vasoconstrictor. Okay. So this loop will be helpful in cutting the lower pole along with the crossing it, so that tissue factors will be released, which will be helping in coagulation procedure. So you have taken out the whole of the tonsil from its bed. After taking it out, there may be some residual bleeding, or there may be profuse bleeding, because bleeding is a very common complication of tonsillectomy. In case of any bleeding, you have to secure that bleeding point. You have to hold that with a artery forceps or the hemostatic forceps, and you have to tie that bleeding point with the help of a suture material. So because tonsil is present deep inside the oral cavity, we cannot tie it the suture just like we're tying the skin. So for that we need a special instrument. This is a knot carrier, or Negus knot tire and ligature pusher or carrier. Negus knot tire. You can see this is a long instrument having a handle and a prong, having a tip which is a curved. This U-shaped tip. Okay, small U-shaped tip through which that you take a bite over the tissue of the tonsil. Then both the ends of the thread you give a knot. That knot you have to push it through this knot carrier, knot pusher, inside the oral cavity up to the site of bleeding. Okay, so it is a Negus knot tire or ligature pusher. So these are hemostatic artery forceps. The artery forceps, because just like in any normal artery forceps, but here in tonsillar artery forceps, these are very long, and this Tips are very thin and very long, and the tip, the middle side of the tip is serrated, so that it will not. If you hold the bleeding point or bleeding artery or vein, once you catch hold of the bleeding point, it will not slip away. So that is why the tip has been made serrated. It is available in various sizes, maybe straight or gently curved. Inner surface of the tip is transverse serrated for better grip, also called a ratchet for locking. This is a ratchet. Once you hold the bleeding point of the tip and you lock it with the ratchet, it will not slip off. So most important, another important instrument is the adenoid curette with cage. This is called St. Clair Thompson adenoid curette with cage. So this is an instrument having a handle, a long this is a curette and this is the cage. Okay, the curette, with the help of the curette, you can curate out the adenoid tissue from the nasopharynx, and the cage is there. Because there is a hinge. This cage is movable. It can move anteriorly or posteriorly. This cage having some serration, having some teeth over here. Once you cut the adenoid tissue, that will not fall again into the oral cavity. This cage prevents it's falling again into the oral cavity and nasal cavity. This instrument is used to curate the adenoids by a blind technique. The curette is introduced behind the soft palate with the blade facing down, held like a dagger. This is most important. This is held like a dagger. And the adenoid is curated from the nasopharyngeal wall in the midline by sweeping movement. The cage is used to prevent slipping of the excised tissue into the throat. During the procedure, the neck of the patient should not be in too much extension, as it may injure the atlanto-occipital joint. Another variety of without cage is known as Beckman's adenoid curette. Another curette is there, but it will not be given to you. That is without the cage. The one will be given to you is with the cage. With the help of this cage, you can prevent the falling of the tissues again back into the nasal cavity. So you have to hold the patient is in supine position. Mouth gag has been placed in its position, and it has been locked with the help of a Daffin Viper stand. You have to the surgeon has to sit or stand at the head end of the patient. You have then he will hold the adenoid curette just like a dagger. In the dagger-like fashion, he has to hold. There we are holding it in a pen-like position, pen-holding position. But here you have to hold it in a dagger-like fashion. You have to insert it with the blade facing towards the upper end of the towards the head end of the patient. You have to insert the adenoid curette through the oral cavity, go behind the soft palate. Okay, you have to engage the curette behind, go behind and engage the soft curette in the adenoid present in the nasopharynx. Then you have to move it in the downward direction, so that this curette will all that will slice off the adenoid from the nasopharyngeal wall. So this is a blind procedure. You have to because you cannot see anything behind the soft palate. You have to go behind and you have to again move the dagger just like in a slow and downward movement, so that the adenoid tissue present in the nasopharynx will be they will be saved off. So the indications, contraindications, and complications you have to go through your book. Next will be discussing something regarding mustard surgery. So the mustard surgery, there are different types of incisions. The indications of mustard surgeries are many. That are different types: safe type, unsafe type. You can go for a myringoplasty. You can go for a mastectomy. Different types: simple, radical, modified radical. Different types are there. So for mastectomy, you have to give a postural incision just behind the pinna. So after giving incision over the skin, just below is the subcutaneous tissue and the muscle. You have to cut the muscle and subcutaneous tissue, then will come the bone, mustard bone covered by periosteum. You have to give incision over the periosteum and elevate the periosteum. So after elevating the periosteum, you have to retract the cut tissues separately, so that the bone will be exposed properly. So to retract the soft tissues after giving incision, you use an instrument called the self-retaining hemostatic master retractor. This is Mollison's self-retaining hemostatic master retractor. Each word is important. You remember the name of the instrument. It's very important. Each word is important. Mollison's in the name of scientist. It's self-retaining. Once you apply this instrument, it will retain in an open position. It will not close automatically. So it is a self-retaining. It is hemostatic because from the cut end of the cut edge of the wound, there will be diffuse bleeding from the cut end of the wound. After applying this instrument, the bleeding will stop because of these different mm, these threads are there, this tooth are there, this tooth will retract the soft tissues and it will prevent bleeding to occur. So this is hemostatic and this is mastered retractor. So Mollison's self-retaining hemostatic mastered retractor. Okay, these are prongs. These are 4 prongs. These are on either of the blade. Besides retracting the tissue and fascia from the field of operation, it can also secure hemostasis by compressing the vessels. These prongs will compress the vessels and prevent bleeding. So where it is used to harvest the temporalis fascia. For besides mastectomy, it is used to harvest the temporalis fascia for the purpose of meringoplasty. It can be used for mastectomy, for tympanoplasty. In head and neck surgeries like tracheostomy and laryngofissure surgeries, any surgery in the head and neck area where a smaller part is to be exposed and the tissues are to be kept separated, we can use a mastered retractor. It can retract a smaller area for a prolonged period. So as I told, after skin, soft tissue, muscle, you have to incise the periosteum present over the mastoid bone, and you have to elevate the periosteum. So this is the instrument which we use to elevate the periosteum from the bone. The name is Parabius periosteal elevator with a thumb rest. This is the thumb rest. Okay, so you have to rest your thumb over that, and the tip of this instrument. This is the handle. This is the thumb rest. This is the tip. The tip of the instrument is sharp. With the help of the tip, you can elevate the periosteum from the bone. Indications: elevate and retract the periosteum in mastectomy, elevate the soft tissues to elevate periosteum and anterior surface of maxilla in Caldwell-Lock and maxillectomy. From the periosteum from any part of the bone, any type of bone can be elevated to this instrument. So after you elevate the periosteum, there is a bone. You have to cut the bone, mastoid bone, in order to reach the mastoid antrum. The cortex of the mastoid bone, you have to take it out. You can take it out with the help of a gauge and mallet, or nowadays we are using a high-speed drill system. So because it is a classical method of teaching is a gauge and hammer. So the gauge we use is Jenkins mastoid gauge. This is a gauge. This is the grip. It has got a handle and the tip. This grip is to be hold with the fingers. You can use a hammer to be struck over here, and this is the tip, which is a curved one and a sharp one. It will cut the bone and take out the bone in pieces. So the tip is curved and sharp. So gauge is an instrument with a curved rounded tip that has smooth beveling. It is very smooth inside and outside. Hence, it cuts bone in a circular pattern. It is held at an acute angle to the bone for cutting it, and a mallet is used for hitting on it. The gauge has been replaced by the elliptical drill in the present day. Uses: it can be used to remove hard bone during mastectomy. You can remove it the cortex of the mastoid bone. Besides that, you can also use it in the Caldwell-Lock operation. You must be knowing what is Caldwell-Lock operation of the maxilla. On the anterior wall of the maxilla, you create a hole and go inside the maxillary antrum and take out or do whatever you want to do inside that. This particular instrument can also be used for a smaller one, of course, can be used to excise the exostosis in the external aortic canal. Any bony growth in the external aortic canal can be taken out with the help of this mastoid gauge, a smaller one. There is a difference between the gauge, chisel, and osteotomy. A gauge is as an instrument. All the three are used to cut bones, but a gauge is having a curved edge and a single beveling. Okay, is a gauge. So it can be a straight gauge, it can be a Benner separate gauge for the septoplasty. This is for mastoid, this is for septoplasty, and this is a chisel. Chisel having a single bevel. But the osteotomy, the beveling is on the both the sides. Unfortunately, I am not having a picture of the osteotomy. The beveling is on one side in a chisel, but on both sides in a osteotomy. This is a mallet known as Heath mallet. You have to remember the name only, Heath mallet. This is nothing but just a hammer. You have to use the gauge to be used along with a gauge or a osteotomy or a chisel. This instrument appears like a hammer and is used along with the gauge, chisel or osteotomy. The gauge is to be hit by a mallet with a movement at the wrist during a septal surgery. While using a mallet, the most important thing is the movement should be at the level of the wrist, not at the level of the elbow, because in the elbow the force will be very high. Only at the level of the wrist you have to move it. So this is about the mallet. So after removing the cortex of the bone, the antrum is now exposed. The antrum it's connected to the air cell system of the mastoid bone. So you have to expose all the mastoid air cell system by breaking the septa in between the air cells. So in order to break the septa or to take out the bone from the mastoid air cell system, you use a particular curette that is known as Lempert's mastoid curette. Okay, this is a handle and this is the tip. The tip is you can see the tip very much. This is just like an ice cream scoop. The scoop we might have seen in parties that they use it to take the ice cream from their box. That is just like a scoop, but it is very strong. You can scoop out bones with the help of these sharp edges. Used to curate chunks of bone from mastoid and ear canal during ear surgeries like tympanoplasty, mastoid exploration, and staphyectomy in particularly. In stapes surgery, what because stapes is present a little deeper inside, and posterior superior bony overhang is there, so you cannot visualize the footprint of the stapes properly in most of the cases. We use this scoop to take out the posterior superior bony wall during staphyectomy. It can also be used to remove granulation tissue and cholesteatoma from the ear canal. So this is Lempert's mastoid curette. Okay, so this is all about ear surgery. Now coming to the nose. So different instruments you'll be given in the examination from the that are used for the nasal surgery. One is this trocar and cannula. This is Tilly Lijui's trocar and cannula. Okay, this is a trocar and this is the cannula. Okay, so this cannula will be placed over here. This it acts like a sheath. Okay, so it has got a handle with a long pointed end cannula. So procedure of antral, where it is used to puncture the maxillary antrum and to wash it. The antral wash out, for antral wash out, it is being used. So procedure of antral puncture, the antral puncture is done in the inferior meatus. Just remember, you'll be always asked in the examination, what is the site of antral puncture? So the next slide will tell you. This is the maxillary antrum. You can see this is the inferior turbinate, this is the middle turbinate. This is the orbit, this is the septum, this is the nasal cavity. So you have to, in the maxillary antrum, there may be some pus collection or some debris in maxillary sinusitis. You have to wash it, or you have to, in case of malignancy, you have to take out some drained out fluid to examine any malignant cell. That is called proof puncture. Okay. So in maxillary sinusitis, you have to puncture the maxillary antrum and wash it. So with the help of this trocar and cannula. You have to insert this instrument in the inferior meatus. Where in the inferior meatus? Around 1 to 1.5 centimeter behind the anterior end of the inferior meatus, inferior turbinate. So this is the anterior of the inferior turbinate, around 1 to 1.5 centimeter behind the inferior anterior end of inferior turbinate. You have to insert the trocar and cannula into the maxillary antrum. Just like this procedure, just like this method, you have to insert it here only, just below the inferior turbinate. Why at this point? This is the thinnest part in the of the medial wall of the nasal cavity. Okay, so here, if you are not functioning here, and here, then here the bone will be very thick. So here is the thinnest part. That is why you have to insert it over here and go inside the maxillary antrum. After you insert into the maxillary antrum, you will feel a sense of giving way. The bone will give way. Suddenly the resistance will disappear and it will enter into the antrum. So after entering into the antrum, you have to take out the trocar and you have to leave the cannula there. Leaving the cannula there, you have to take out the trocar from inside. Okay. Now the hollow structure is there in connecting the maxillary antrum to the outside. Then you have to connect it with the syringe, and the warm saline will be there. You have to irrigate the nasal cavity with the help of this syringe. This is called a Higginson syringe, and the maxillary antrum will be washed out. So the uses diagnostic proof puncture to obtain aspirate from the maxillary sinus for analysis. The sinus, any collection inside the sinus, you have to take out the sample for analysis. To drain pus in the maxillary sinusitis, installation of medicine into the maxillary antrum, or in case of porantral fistula, you have to diagnose if there is any fistulous connection or not. This is all about antral puncture cannula. Trocar and cannula. So the syringe that you are seeing here is a Higginson syringe. So this is nothing but a made up of red rubber having a ball and two tubes attached at the two ends. One end of the rubber tubing ends in a valve. Okay, this is a valve, one-way valve. If you this end will be inserted in the water, and this end will be connected to the trocar cannula, to the cannula. So once you squeeze it, air will come out outside, air from inside of this balloon will come outside, and when you release the squeeze, what will happen? The air will enter with a negative pressure inside to the ball. Okay, and again when we squeeze, the water cannot go in the opposite direction. Okay, because there is a one-way valve. The water has to come out to the through this end only. Okay, so this is a one-way valve is there. Water will come inside, get collected in the balloon, and when we press the balloon again, it will go in the opposite in this direction, and it will come out through the cannula and irrigate the maxillary antrum. The capacity of this bulb is 50 ml, and it is made up of red rubber material. So it is used for antral washout, and it is for nasal douching in atrophic rhinitis cases. So this is Higginson's syringe. Another important instrument that will be given to you is for fracture of the nasal bone and the septal fracture. So this is as forceps and this is Walsum forceps. These are nothing but these are just like chumuta you might have seen in your kitchens. This is just like a chumuta. So the difference between as forceps and Walsum forceps is the tip is angled. Okay, as forceps the angled tip is there, angled blades are there, and it is used. This as forceps is for correction of the septum. Any fracture or any deviation in the septum, you have to insert the tip of this forceps, one tip in each nostril. You have to close it, and you have to do a maneuver to relocate the fragmented septal parts. So there is a gap between the two tips of the as forceps, so that septum will not get crossed. Even after closing it, there will be a little bit gap. Okay, so that the septum will be there in between, and it will not be pressurized. Is to elevate and straighten the septum, and it is a stout one, is a larger one. But the Walsum forceps is the blades are straight, and one blade is covered with a rubber tubing. Okay, because it will be placed over the skin. This will be inside the nasal cavity, and this will be outside. So this will be placed over the skin. So in order to prevent injury to the skin, the one end is one of the tips is covered with a rubber tip, and there is no gap in between. When you close it, it will be closed completely. There will be no gap. Used to refracture and realign the nasal bones. Okay, and it is smaller in size. So this tube may not be there, but you just remember the straight one is the Walsum forceps, and the curved one, the angled tip, is the as forceps, as septal forceps. So next, before going to the next surgery, that is tracheostomy. Let me briefly tell you about the tracheostomy. The indications you must be knowing. There may be emergency tracheostomy, there may be elective tracheostomy. Different types of incisions are given on the anterior part of the neck in different types of tracheostomies. Particularly in emergency tracheostomy, we have very little time. If you do not do the tracheostomy within minutes, the patient may die also. So you have to be in hurry. So therefore, you have to give a vertical incision over the anterior part of the neck. But in elective tracheostomy, you have to be more cautious about the cosmesis of the patient. So you have to give along the skin crease of the of the neck a transverse incision. Okay, here I am showing you a um, elective tracheostomy. You give a skin incision over the anterior part of the neck, just 2 centimeter above the sternal notch, uh, 2 fingers above the sternal notch, neck in the extension position, 2 fingers above the sternal notch. You have to give a skin incision. You have to retract the skin. Just below the skin is a platysma, the soft tissue, subcutaneous tissue, then will come the platysma. After you incise the platysma, you can get the strap muscles. Okay, the strap muscles, you have to pull them apart. In between will come the anterior jugular vein. You have to retract the anterior jugular vein also. Then you will expose the anterior wall of the trachea covered with the pretracheal fossa. Okay, so after excising all the soft tissues and muscles, we will expose the anterior wall of the trachea covered with pretracheal fossa. You have to again give an incision and retract the pretracheal fossa to expose the trachea. Trachea is made up of different circular rings of cartilages connected by soft tissues. So there are different rings connected by intertracheal connections. So after exposing the trachea, you have to give a incision over the tracheal antitracheal wall to create a window. Okay, so this is a tracheal. This is one tracheal ring, another tracheal ring. You have to give a cruciate incision in the space in between and along the tracheal rings. So one incision like this, one incision like this. You have to create a window on the anterior wall of the trachea. And after creating this window, you have to put a tracheostomy tube. While putting a tracheostomy tube, we have to separate this the soft tissues and the cartilages apart so that the tube will get inserted easily. So for that, we need a particular instrument known as tracheal dilator. With the help of tracheal dilator, we separate we make the opening wider so that we can insert a tube. And after putting the tube, this is the position of the tube. This is the outside end, this is the inside end, this is a curved tube, so that air will enter and it will go to the lungs. So what are the indications? So if there is an obstruction in the upper part of the upper airway, so that air cannot enter into the trachea through this route, you have to bypass the route and to create a stoma over here, and air will enter to the lung through the tracheostomy, the stoma. Okay, so briefly, this is tracheostomy. There are many things into it that we will go through in your book. Everything it will take a very long time. So I told you this before because next instrument I'll be telling is a tracheal dilator. This is Trossius tracheal dilator. It is an instrument, very useful instrument. Without this, we cannot put a tracheostomy tube. This is a tracheal dilator having a this is a guard. But there is no catch. Okay, when you squeeze both the handles, the tip will open up. Okay, this is tip is closed, but when you push them, hello, yes, hello. Anyone wants to tell anything?
Yes, sir.
Yes. Any problem?
No, sir.
Should I continue?
Yes, sir. Please continue.
Okay. I know it is taking a longer time, but we don't have any option also because tomorrow is a holiday. The day after tomorrow is also a holiday, and Monday you are having exams, so you have to be patient. Everyone is feeling hungry, I know, but what to do? There is no option. By afternoon we have to finish it. Okay, so please cooperate. Huh? So this tracheal dilator. When we close the tracheal the handle, the tip will open up. So you have to insert the tip in a closed fashion into the tracheostomy wound, tracheostoma you have made. Then you have to open the tip so that the cartilage will get separated and the opening will enlarge so that you can put the tube inside. The instrument used to dilate the tracheostoma during or after the tracheostomy to insert the tracheostomy tube. Allows easier introduction of the tracheostomy tube and prevents formation of a false passage. Okay, so tip is carved so that it will go from this will be this part will be there in the stoma, and the curved end will be facing downwards. The tube will be going and getting placed inside the lumen of the trachea. So sometimes you may confuse this tracheal dilator with a artery forceps that I have already shown you in the tonsillectomy. Okay. See, so you can confuse this tracheal dilator with the artery forceps. The difference is there is a catch over here. Okay, there is no catch in the tracheal dilator, but there, a lock is there. Okay, so this catch is not there in tracheal dilator, and the tip is, though it is curved, there is no serration or there is no ridge in the tracheal dilator. Okay. Here, the pressing the handle of the instrument, tracheal dilator, what happens? If you press both the handles, the tip will open. But in artery forceps, if you press the handle both the handles, the tip will close more tightly. Okay. So this is the difference between the artery forceps and tracheal dilator. And the ratchet is absent here. In the tracheal dilator, this catch or ratchet is absent, but in artery forceps it was there. Inner aspect serrations are absent. Here the tip is very smooth. There is no serration in the inner aspect of the tip, but in artery forceps it was there. So another instrument you will be in the tracheostomy context you will be given in the examination is isthmus blunt hook. Okay, this is nothing but a hook-like structure having a handle. So when we are doing a tracheostomy, what happens here? When we are giving incision over here, the, this is the place of the thyroid gland. So in obese patients or in case of any patient having a enlarged thyroid, so the thyroid gland will come in the way of your incision and of your surgery. So you cannot just incise or excise the thyroid gland on order to do a tracheostomy. So you have to pull the thyroid gland superiorly so that your field of vision becomes clear. Okay, so pull the thyroid gland superiorly. You use a isthmus blunt hook. You have to you have to catch hold of the isthmus with the help of this hook, and you have to pull the thyroid isthmus superiorly using this hook, so that you can expose the trachea more clearly. Okay. So before going into the tracheostomy, different types of tracheostomy tubes, let me tell you how what is the disposition of a tracheostomy tube in the neck. So here is the tracheostomy site. You have inserted this tube inside, and it is going down into the trachea. Okay. So behind the trachea there is a esophagus. Okay. The anteriorly there is a airway, air passage, and posteriorly there is a food passage. Okay. So the air, after putting a tracheostomy tube, the air is the normal air, normal breathing. The air in the normal breathing, instead of coming through the nose, it comes through the tracheostomy opening. The air comes inside, and the exhaled air also goes outside through this tube. This is just a bypass to any obstruction in the upper part of the airway. Suppose there is a large tumor or a pharyngeal tumor, or there is a carcinomatous growth in the larynx, so that patient cannot able to is not able to breathe through the natural passage. So you have to have created a bypass to so that patient can survive and can take breath. Also, in some elective cases, like in a prolonged, in case of prolonged ventilation, if the patient is in ventilator, just like in the present scenario in COVID, few of the patients they have to be in the ventilator for a very long period. So in those cases, we instead of putting the endotracheal tube to the oral cavity, we create a tracheostomy, because by tracheostomy decreases the dead space. Here, if you put a tube, and here if you put a tube, at least this part of the dead space is minimized if you put a tracheostomy tube. Similarly, in case of any difficult intubation, when in oropharyngeal surgeries, any oral malignancies or pharyngeal malignancies, any oropharyngeal trauma patients, where we cannot put a endotracheal tube for general anesthesia through the oral cavity, we go for a tracheostomy, put the tracheostomy tube and give anesthesia through this. Okay, so that surgery in the oral cavity or the nasopharynx or oropharynx can be, or in the larynx can be performed easily. Okay, so this is the disposition of the tube. This is the anterior wall of the trachea. This is, you can see the tracheal rings here. This is the tracheal ring, and the interval there is a stoma, a tube is entering and going inside the trachea downwards. Okay, so why I am shown this picture? Because next will be the different types of tracheostomy tubes. So two types of tracheostomy tubes will be given in the exam. One is Jackson's tracheostomy tube, another will be Fuller's tracheostomy tube. Okay, so what is the difference? Jackson's tracheostomy tube is a uh, complete tube. Okay, it consists of three parts. One is outer tube, one is inner tube, one is a pilot or a obturator. Okay, this is the inner tube, this is the outer tube. The inner tube is inserted inside the outer tube. Okay, you can see this is the inner, this is the outer, and this inner has been inserted in the outer tube. Okay, and this obturator is placed inside the inner tube. When we are putting a tracheostomy tube, Jackson's tracheostomy tube into the tracheostomy opening, we place it along with the obturator in the inner tube. Okay, obturator in the inner tube in the outer tube. The whole system we are inserting into the opening. After putting the tube, you take out this pilot. Why we are putting this pilot or the obturator? Because the tube will create a trauma while inserting the tube inside the tracheostomy opening. You may injure the posterior wall of the trachea. You may injure the anterior wall of the esophagus if because the tip is sharp. So in order to prevent that, or some tissue, soft tissue may get locked inside the inner tube, and that will block the inner tube. So in order to prevent that, while inserting, we give a obturator. Okay, so the parts are inner tube. Outer tube contains a collar and a locking mechanism. Yes, this is the outer tube. This is the outer tube. This has got a collar. This is the collar and a locking mechanism. You can see this is a locking mechanism. This is the inner tube. It has got two wings and this and a groove over here. This lock when it is in horizontal position, it is locked. If you rotate this lock upwards, it will open up so that you can take out the inner tube. So this is typical of this Jackson's tracheostomy tube. There is a lock. Okay, this locking mechanism is not there in Fuller's tracheostomy tube. Okay, so tracheostomy tube is inserted after you make a opening in the anterior wall of the trachea, and this this slot you can see. You can use a thread to tie it around the neck. On both the sides, you can see a thread. This is the inner tube opening. Inner tube has been placed inside the outer tube. This is the locking mechanism. This is a this is the collar. Okay, so the pilot is there for introducing the tube into the trachea so that injury is not caused to the posterior wall. So what are the disadvantages with this tracheostomy tube? Because tracheostomy tube is a rigid one. I mean the complete completely tubular without any hole in with it. So what will happen once you put it? Suppose this is a Jackson's tube. Once you put this tube in the trachea, normal air through the nose cannot enter. Okay, so this is one disadvantage. Phonation is not possible because air is not entering. No air is entering through the nasal cavity or through the larynx. So phonation is not possible. Normal air cannot enter into the nose. Okay, which is a advantage of the Fuller's tube. I will be telling you. Phonation is not possible. Patterns of the natural air passage cannot be checked by blocking the tube. There is a risk of granulation tissue formation. These are the disadvantages of the Jackson's tube. So different size of Jackson's tube are available. You can see this is a 18 gauge 18 size tube. The French gauge is 3 times the outer millimeter. Suppose it is 6 millimeter outer diameter. Outer diameter is 6 millimeter. 3 times that of his French. The size will become 18. Okay. So it comes in 18, 20, and 22, just like that sizes. So the disadvantage of this Jackson's tube is overcome by Fuller's bivalve tracheostomy tube. This is a metallic tracheostomy tube and has an inner tube that is longer than the biflanged outer tube. You can see it has also got two tubes, inner tube and outer tube. This is the inner tube, this is the outer tube. Inner tube is slightly larger than the outer tube. Here it is not visible properly, but the inner tube is slightly larger than the outer tube. Okay, so that the outer tube is never blocked. And the outer tube is biflanged. It has got two flanges. Okay, this prevents the outer tube from getting blocked by the secretions. The inner tube can be easily removed for cleaning. So once you insert the system into the stoma. When you suspect there is some blockage inside the inner tube, you can take out the inner tube, clean it again, and again reinsert. So inner tube can be removed. There also injections you can remove the inner tube, clean it, and again reinsert. Also, the posterior wall of the inner tube has an opening. You can see there is an opening in the posterior wall. Okay, here, so that when you insert a if there is a hole here, then what will happen? The patient can take some breath through, if at all space is there, some breath, some air will come through the natural path along with this stoma end. From the natural path, some air will come and pass through the this opening in the posterior wall. So that phonation can happen in some to some extent, and we can check by closing this end of the tracheostomy tube. If the patient is still able to take maintain his normal ventilation, we assume that the airway is patent, because here there is a hole through which air can pass. So we can check the patency of the natural airway by just closing the opening of the tracheostomy tube. Okay, so this is the advantage of the Fuller's tube. So inner tube has an opening that permits the patient to breathe through the nose and phonate. The two flanges of the outer tube can be compressed for initial introduction into the trachea. See, these two flanges can be compressed, and while inserting the tube into the stoma initially, these two flanks can be compressed and can be inserted just like a only the outer tube can be inserted. So there is no without having any chance of injury to the uh, posterior wall. So there is no operator is required in Fuller's tube. Okay. So this itself acts as a self inserting mechanism. The two flanges of the outer tube can be compressed for initial introduction to trachea. Hence, a pilot is not necessary for introduction. The compressed flanges of the outer tube hold the inner tube in place and prevent it from getting coughed out. See, when we after inserting the outer tube, when we insert the inner tube, what will happen? This outer tube, the two flanges will keep the inner tube in place by pressing. So that what is the use of this lock? The lock is there because if there is when you place some foreign body in the respiratory mucosa, there will be a coughing reflex. So similarly, when the tracheostomy tube is inserted into the trachea, there will be huge coughing reflex. So the patient will be coughing continuously. So in that coughing, the inner tube may come out forcibly. So in order to prevent that throwing away of the inner tube, we have to lock it along with the outer tube in a Jacksonian tube. But in Fuller tube, because the inner tube is kept compressed by the flanges of the outer tube, there is no need of a locking mechanism in Fuller's tube. The parts is biflange outer tube, collar present to tie the thread. You can see the collar. You can tie the thread over here, and inner tube has two circular rings to grasp, remove, and insert the tube. Okay, so the two circular rings are there to take out the tube and reinsert the tube. The disadvantage is that the tip of the flanges can injure the tracheola. When it is sharp, because metallic tubes we can use it can be reused again and again. But the recent PVC tubes, that is disposable ones, that is used for only for once. But this metallic tubes can be used again and again, and after repeated uses, these flanges become very sharp and they can injure the tracheal valve. So some cases you can see, as you can see, this has become very old and the flanges have become already bent. So someday it will break and fall off. So these flanges can break after long use and present as a foreign body. It can fall and go inside the trachea into the lungs, and it can act as a foreign body. And there is also a risk of granulation tissue formation because it's a metal inside the tracheal mucosa. So I have already told you the difference between Fuller's and Jackson's. Outer tube is biflange in Fuller, and there is no flanges in Jackson's. Lock for inner tube is absent in Fuller and that is present. Vent for breathing and phonation is there in the Fuller and absent in Jackson. And pilot for introduction is absent in Fuller and present in Jackson. So this is all about the instruments that will be given in the examination starting from 16th of this month. So next we'll be finishing up very quickly. There are few radiological X-rays you will be given in the examination to identify. So first in the series is this is a X-ray of the neck. So whenever just remember, it is very please don't tell whenever you are given such type of X-rays in X-ray. What is this? Of course, this is a foreign body in the esophagus. Don't tell sir this is a foreign body. Okay. So people, I have seen many people, they have the habit of telling, sir, this is a foreign body. So this is not a foreign body. This is an X-ray. You just tell that, sir, this is an X-ray of the neck, soft tissues of the neck. This is anterior view, epi view, and this is lateral view, showing a circular radio opaque shadow over the anterior part of the neck. Okay. Possibly a foreign body, radio opaque foreign body, possibly radio opaque foreign body, circular radio opaque foreign body. When you are asked what is that foreign body, maybe you can say it may be a coin, or it may be any metallic battery, alkaline battery, or any metallic circular foreign body, radio opaque foreign body. So then again you will be asked what is the site of the foreign body, which part of the, whether it is in esophagus or it is in the trachea. Okay, so how to know that? You cannot say from the epi view. For that, you need to have a lateral X-ray of the neck. So in the lateral X-ray, what we can see this is the air shadow. This is the air shadow in the anterior part of the neck. This is the epiglottis. You can see this is the oral cavity, this is the nasal cavity, this is the hard palate, this is the tongue, this is the vallecula, this is the epiglottis. Just below the epiglottis, you can see this is the beginning of the, this is the vocal cord, and this is the beginning of the subglottic area and beginning of the trachea. So anteriorly there is a air shadow. So the airway is patent. There is no obstruction in the airway. So the foreign body is just behind the air column. So this is the area of the esophagus, just behind the esophagus and just behind the trachea, and anterior to the vocal vertebral column is the esophagus and the prevertebral muscles. So since the shadow is there in the esophageal area, so you can say the foreign body is in the esophagus. So this is a X-ray of soft tissues of the neck, anterior epi view and lateral view, showing a circular radio opaque shadow in the anterior part of the neck. From the lateral X-ray, it is evident that the foreign body is in the esophagus. And this foreign body can be possibly a coin, or it can be alkaline battery, or in some cases, in some children, they have the habit of tying up a circular locket in the neck. So the thread will not be visible because it's a cotton thread that will not be visible in the X-ray. So thread is not visible. If the lock you're able to see is the first is this is the front, this is the orbit on both the sides. These are the orbits. This is the maxillary sinus on both the sides. This is the frontal sinus on both the sides. This is the nasal septum you can see. Okay, so these are the ethmoidal air cells on both the sides, and this is the shadow of the sphenoid sinus. You can see this shadow is the sphenoid sinus. So this is a master. When you are giving in the examination, you have to tell this is X-ray of paranasal sinuses, showing both the maxillary sinuses, frontal sinuses, nasal septum is in the center, ethmoidal air sinuses are there, but the pathology is there. There is a polypedal change in the mucosa of the antrum of the left maxillary antrum. Okay, so you can see this is a X-ray of paranasal sinuses having all the sinuses clearly visible, and there is a polypedal change in the left maxillary antrum, possibly antral polyp, antral mucosal polyp. Okay, so this is about the PNS X-ray. So this is all about the instruments and X-rays that you will be given in the examination. Hope this class was of some help to you in revising the things. The rest you have to go through your books, and my suggestion will be, please go through your books today only. After finishing this class, read the relevant chapters from the book today only, because tomorrow you may not remember all the things, that it might evaporate. So for a better understanding, better remembering, go through the book today only. So hoping you have done well in the theory part of the examination, and see you in the practical class on Monday. Wish you all the best. Thank you.
Thank you, sir.
Thank you.